Manipulation for lumbar disc herniations confirmed by MRI and exam. Until recently, we would expect a negative reaction to the idea of manipulating a patient with a lumbar disc herniation, a concern of worsening the condition or even causing cauda equina. Even many chiropractors deferred to less aggressive approaches such as flexion traction, McKenzie, or SOT, for example. Yet for some chiropractors, it is common practice to attempt a trial of manipulation for patients with pain radiation into the leg, whether a radiculopathy or not. But this approach remained untested by well-designed studies until recently. More recently, we have several studies which have pointed in the direction of not only being a safe, but also an effective approach for patients with lumbar radiculopathy due to disc herniation. In fact, the recent North American Spine Society guidelines for lumbar radiculopathy include manipulation as a viable option based on the available research. Subsequent to these recommendations, a couple of newer studies add more weight to the argument for the alternative use of spinal manipulation instead of a spinal injection and preemptory use prior to surgery. The focus of our discussion is on a new publication in JMPT in 2014. Although a new study, it is important to point out that this is an extension and updating of information that was presented in a publication from 2013 entitled Symptomatic Magnetic Resonance Imaging Confirmed Lumbar Disc Herniation Patients, a comparative effectiveness prospective observational study of two age and sex-matched cohorts treated with either high-velocity, low-amplitude spinal manipulative therapy or image-guided lumbar nerve root injection, published in JMPT. In that study, 76.5% of SMT patients reported being much better or better, while 62.7% of nerve root injection patients reported being much better or better. And for numerical pain scale ratings, both treatment groups had significant decreases in their NRS scores at 1 month, with a 60% reduction for the SMT patients and a 53% reduction for the nerve root injection patients. It is standard in the research world to maximize efforts in time and money by designing a project that can be used as a generator for spin-off studies based on either follow-up or broken down into different comparisons such as cost in one study and effectiveness in another. Although a common practice, it is also viewed as requisite that transparency allows readers to see the relationship between these overlap studies. After communication with one of the principal investigators, it was confirmed that this more recent publication, in fact, uses about 1/3 of the same patients who were in the manipulation group in the previous study, but adds newer patients in the more recent study publication. There are several differences in the focus and reporting between these two studies. In the first study, other than age and gender, demographics were not clearly compared. In the first study, the rationale for the types of manipulation was not clearly explained, and in the first study, there was only short-term follow-up. The more recent study is entitled Outcomes of Acute and Chronic Patients with Magnetic Resonance Imaging Confirmed Symptomatic Lumbar Disc Herniations Receiving High-Velocity, Low-Amplitude Spinal Manipulative Therapy, a prospective observational cohort study with 1-year follow-up by Lehman et al., published in JMPT. This is a Swiss study conducted in a single chiropractic practice in Zurich using a standardized treatment approach. There were 3 doctors of chiropractic who performed the exams and treatments. They worked closely with the University Chiropractic Medicine program. This was a prospective cohort design intended to evaluate patients with low back pain and leg pain due to disc herniation treated with high-velocity, low-amplitude spinal manipulation, using outcomes that included a self-reported global impression of change and pain levels at various time points up to 1 year, and secondly, to determine if outcomes differ between acute and chronic patients. So who were the patients? The inclusion criteria stipulated that patients were between 18 and 65 years. They had to have back pain and moderate to severe leg pain in a dermatomal pattern, and at least one of the following: decreased straight leg raise testing, deficits in detection of cold, reduced response to pinprick, decreased muscle strength and a corresponding myotome, and a decreased or absent deep tendon reflex corresponding to the involved segment. And there had to be MRI-proven lumbar disc herniation at the corresponding symptomatic spinal segment. Exclusion criteria were standard, including tumors, infections, fractures, Paget's disease, prior surgery, cauda equina, neurogenic claudication, and pregnancy, among others. It's important to note that the strength in the process of this study was the inclusion of only disc herniation as a cause and effect of pain and neurological findings. The evaluation included a neurologic assessment consisting of deep tendon reflexes, dermatomal sensory testing, and motor function testing of the lower extremity. A baseline orthopedic examination was also performed with special interest in nerve root tension signs such as straight leg raise, bowstring, braggarts, and a Valsalva maneuver. This was repeated at every follow-up visit. To reach a total of 148 patients with 1 year's data, 171 patients with baseline data were enrolled. Unlike the original study, this study goes further in comparing demographic data. There were no significant age differences between the sexes. There were no significant differences between the sexes for the baseline numeric rating scale for low back pain and leg pain scores, the duration of complaint, or baseline oswestry scores. Another strength is the categorization of patients into acute versus subacute versus chronic. Of the 148 patients, 79 had symptoms of less than 4 weeks and were labeled as acute. 37 had symptoms of 3 months or longer and were labeled as chronic. Subacute patients, that totaled 31, were not included in the subgroup analysis. There were no significant age differences between the acute and chronic patients. Outcome measures included 2 11-point numeric rating scales, one for leg pain and one for low back pain, and an oswestry pain and disability questionnaire. Telephone interviews were conducted at 2 weeks, 1, 3, and 6 months, and 1 year after the initial consultation. The patients answered the same oswestry pain and disability questionnaire, global impression of change, and rated his or her pain intensity on the NRS for both the low back pain and leg pain. The Patient Global Impression of Change scale is a 7-point verbal scale, with 1 being much better, 2 better, 3 slightly better, 4 no change, 5 slightly worse, 6 worse, and 7 much worse. Only patients with scores of 1 or 2 were considered improved in this study. Disc herniations were categorized as intraforaminal or paramedian. The differentiation is based primarily on an axial MRI with herniation in one of several potential areas, starting with a central herniation, a paramedian herniation localized to the lateral recess, a foraminal or intraforaminal zone in the pedicular area, and an extraforaminal zone which is far lateral. Manipulation was based on the type of herniation. For an intraforaminal disc herniation, a modified push adjustment with a kick was performed. The affected side was down. The doctor took a mammillary contact and performed a push from P to A. For the paramedian disc herniation, a pull adjustment with a kick was performed with the non-affected side down, a spinous process contact, and a pull with a kick. So the obvious question is, why assign specific maneuvers based on the type of herniation? The researchers explain this by the following. Gapping the foramen on the affected side for an intraforaminal herniation would induce a more normal movement pattern, decrease the pressure on the disc and nerve, release adhesions, allow efflux of chemical irritants, and stimulate the receptors in the surrounding tissue. This is all, of course, hypothetical. For a paramedian herniation, gapping the unaffected side is utilized, but with the same therapeutic goal as the intraforaminal approach, although they state that the opening of the foramen seems to be of lesser importance for paramedian disc herniations. At 2 weeks after the start of treatment, a large proportion of patients reported substantial improvement at about 70%. This increased at 1 month to 80%, and at 3 months up to 90%. Then was a period of stabilization at the 6-month and 1-year data collection time points. Although the proportion of patients reporting improvement continued to increase up to the 3-month time point for acute patients, this then stabilized, whereas for the chronic patients there was continued improvement at both 6 months at 88.6% and 1 year at 89.2%. The pain and disability scores continued to decrease for both groups up to 3 months after the first treatment and then stabilized at the 6-month and 1-year time points. Not surprisingly, these changes were faster and more dramatic for the acute patients. For acute patients, the degree of leg pain was inversely associated with improvement in the first 2 weeks after treatment, meaning the higher the baseline reporting of leg pain, the more likely the improvement. At both 3 and 6 months, the only predictor of improvement was the baseline Oswestry Pain and Disability Questionnaire score. The higher the baseline OPDQ, the more likely the pain was to improve. These results are impressive, yet a couple of questions arise as a result. First, given the marked improvement in the acute patients, what's the comparison to natural history? And secondly, what happened to the remaining patients not included in the final analysis? The natural history of sciatica in acute disc herniation patients is normally quite high. 36% report major improvement after 2 weeks, with 73% having resolution of their leg pain by 12 weeks. Yet these study results seem to beat that natural history. Regarding the patients in this study, 2.1% of patients reported being worse or slightly worse at 3 months, and 2.8% feeling worse or slightly worse at a 1-year follow-up. There were no cases of cauda equina reported. Even though 3 patients reported improvement at 1 month, they elected to have surgery, as did 1 patient who elected to have an epidural injection. The take-home points? As in other studies, leg pain was not a negative predictor for recovery. In fact, having a higher degree of leg pain was predictive of a response to SMT. Although most clinicians find research studies interesting but not impactful for their practices, this study and its predecessor are exceptions. It is not inconsequential that there is now literature support and guideline support in the North American Spine Society recommendations for the use of spinal manipulation with patients with disc-related radiculopathy. These newer studies and recommendations transform the preconceived notion that SMT is a risky therapeutic endeavor to the level of literature-supported alternative that is both safe and effective. Obviously, decisions of whether to employ SMT on a given patient is based on the context of that patient, including the doctor's comfort level and the patient's willingness to try this alternative approach.